Say good afternoon and welcome to the group meeting for Chapter 932 of the 2020 Acts of Assembly. This meeting is being conducted in a completely virtual environment and is being recorded. There are several things that we would like to review before getting started. First, members of the work group, please mute their lines when you're not speaking, as this will reduce the amount of background noise on the call. We also ask that due to the virtual nature of the meeting, you please identify yourself each time you speak so that staff can accurately record the minutes of the meeting. For those attendees who are not members of the work group and who have signed up to speak during the public comment time, when we get to that public comment period, you will be unmuted by the host. We have today several invited speakers presenting to the work group. Each speaker has been asked to speak for 20 minutes with 10 minutes for questions and answers. We ask that all comments and questions directed to the speakers be specific, constructive, and aimed at their presentation and their subject matter expertise. And we appreciate their participation today. Because of the time allotted to the outside speakers, if we have more public comments than time allows, we will reserve time at the end of the agenda for additional comments from the public. Ms. Allen, would you please call the roll?
Alicia Black Hackett. Megan Green.
Here.
Judy Jackson.
Here.
Karen Brem. Joni Latimer.
Here.
Gail Thompson. Jewel Brana. Catherine Paxton. Charlotte Riddell.
Here.
Elizabeth Carter.
Here.
Corey Tillman Wolf.
Here.
Kurt Elward.
Here.
Barbara Seymour.
Here.
Randall Stamper. Todd Barnes.
Here. I'm here.
Thank you. Heather Legary. Sam Kukich. Bob Kukich. Erin Hines.
I'm here.
Susan Hines.
Here.
Lionel DeCur. Senator Kiggins.
I'm here. Thank you.
Christina Holloway. Dana Parsons.
Dana Parsons is not here, but Melissa Andrews is from Leading Age Virginia.
All right, thank you. And Alicia already emailed me and told me that she was going to be late to the meeting. So, April Payne.
Here.
Scott Johnson.
I'm here.
Vivian McDaniels.
Present.
Joe Hilbert. Heather Anderson.
I'm here.
Dr. Pratt.
Here.
Okay. And I know Ms. Kukich Mr. and Mrs. Kukich did not answer when we went through, but I do see you all in the attendees list. I'm going to manually unmute your line for you, okay? Ms. Kukich, are you there? Mr. Kukich? Can you hear me? Okay. All right, that concludes the roll call. If anyone has any issues with their audio, please use the chat function to let me know. It's hard for me to have this the WebEx full screen and also keep an eye on my email at the same time because I'm working off a laptop here. So if you need something, please reach out through the WebEx chat. Excuse me. That concludes the roll call, Dr. Pratt.
Thank you, Ms. Allen.
For the agenda today. Oh, sorry. Go ahead.
Go ahead.
I was going to say, for the agenda today, we have the public comment period, followed by the presentation by Dr. William A. Hazel, Jr. about the Claude Moore Scholars Program. Then we have several speakers from the Department of Medical Assistance Services, Sonia Lee Austin, who's going to be talking about Medicaid rate setting and sources of Medicaid funding in Virginia, along with Terry Smith, Tim Catherman, and Evelyn Hardwick, who are going to be talking about the DMAS and Medicaid incentive programs that are funded through the civil monetary penalties. Then Megan Green, who is with the Office of the Chief Workforce Advisor, will be talking about workforce development programs. And then Keith Hare, who is the president of the Virginia Healthcare Association and Virginia Center for Assisted Living, will be talking about recruitment and retention, Medicaid fundings, recommendations for the workforce, and pathways for implementation. And then we will wrap up with discussion of next steps and any other business.
Thank you, Ms. Allen. We are now at the public comment period on today's agenda, and let me review, please, how this will work. When you registered for this meeting, there was the opportunity to sign up to speak on a topic. The list of persons who signed up to speak was finalized at 11:30 this morning. Pursuant to the Board of Health's public participation policy, each speaker will have a maximum of 2 minutes in which to speak. There will be a countdown timer on the screen, and a bell will ring when the time has elapsed. If the bell rings while a person is speaking, that speaker will be allowed to finish the sentence, and then the speaker will be muted, and the name of the next speaker will be called. You will be unmuted by the host when it's your turn to speak. In addition, all speakers are reminded that this is an opportunity for you to address the board on any topic of your choosing. However, it is not a question and answer period, and there will not be any dialogue back and forth between speakers and work group members. If we have more speakers than the time allotted now, there will be time at the end of the meeting for those speakers to speak under the same rules that have been outlined for this public comment period. Ms. Allen?
All right, thank you. If you'll just give me 1 second, I will share the countdown timer with everyone so they can see it. All right, so you should see the 2-minute counter on your screen. We have 3 speakers signed up for today. The first is Erin Hines. Are you there, Ms. Hines?
Yes, I'm here.
All right, whenever you're ready, I'll start the timer.
All right. I'm ready.
All right, there you go.
Hi, my name is Erin Hines. I'm a member of Dignity for the Aged and also work full-time as a CNA. And I wanted to share something that I posted on a CNA Facebook page and to give you this insight. This is what I posted. Since CNAs provide 90% of care in long-term care facilities, I'm wondering if anyone from administration to the owner or a state official has ever come to you or your coworkers and asked what they could do to make your job easier or better. I received 102 responses. 76 of those said no, they had never been asked that question. That's 75%. 12 said yes, but did nothing. Nothing helped, nothing changed. 9 simply said yes, and only 5 of those 102 said yes, and they received help. Here's a sampling of some of the CNA responses. 27 years and never been asked. Not once in 12 years of long-term care have I been asked this. The hospital I'm at asks every day. They asked me once I put in my 2-week notice so I would stay. It's unheard of to value our opinion. The answer would be staffing, and since admin keeps cutting that, they will never ask us. No, not even with only 1 aide on the floor or only complain about what isn't being done. They only ask when state is in the building. Besides that, we are on our own. No, they just dictate everything without asking opinions, even though none of them have ever been CNAs. My thoughts. CNAs are terribly short-staffed, underpaid, unappreciated, and are treated like second-class citizens, yet they provide 90% of resident care. It's no wonder that we have a major retention issue in our facilities. Does anyone actually care about our many CNAs and the residents they care for? It seems that if all people in the decision-making process cared about the CNAs would have been listened to and these issues would have been taken care of years ago.
All right. Thank you, Ms. Hines. All right. Next up, we have Ms. Sam Kukich. Ms. Kukich, are you with us? I can hear something in the background. Is that you, Ms. Kukich? Okay. I'm going to circle back to Ms. Kukich since she seems to be having some audio difficulties. The next person we had listed was Ms. Susan Hines. Are you there?
Yes.
All right. 2 minutes whenever you're ready to start.
Okay, I'm Susan Hines. I'm also with Dignity for the Aged. Recruitment and retention will continue to be an emergency due to the baby boomer generation flooding into our nursing homes. I'm a teacher, so I want to talk about recruitment for a minute. I believe that a beautifully designed poster placed in every high school in Virginia would be a great recruiting tool for the cost of $20,000. I didn't even know what a CNA was until my daughter became one, so I think advertising is important. As far as retention goes, we must require ratios in Virginia. This is how bad the situation is here. Even before the COVID pandemic, we were losing 380,000 residents per year in the United States due to infection. Where is the outrage over these deaths? Infection happens due to lack of care. One CNA cannot possibly provide appropriate care for 20, 30, 40, 50, or even sometimes 60 residents. In my research, North Dakota ranks very high in every single survey, and they require 3.96 hours per resident. In those same surveys, Virginia ranks between 36th and 40th in the United States. According to some research that my daughter Erin Hines did on CNA responsibilities, 4 hours is needed to provide quality care. So North Dakota is right on track. Virginia has 170 nursing facilities, and I was shocked to see that 90 of those are on the watch list. That means with 19,000 residents, approximately 10,000 are at risk. Virginia must require ratios in order to provide quality care for our elderly.
All right. Thank you, Ms. Hines.
Thank you.
Ms. Kukich, what I'm going to do is I'm going to manually unmute your line, and I'm going to see if that will give you or allow you to speak. So just 1 second. Okay. Ms. Kukich, I've manually unmuted your line. Can you test your audio right now? I'm not hearing anything, and I'm not seeing any indication that there's background noise or anything being picked up. So, and I see you just muted yourself back. Okay, so 1 second. I'm going to see if I can try and get you set up here so you can. Okay. I can see that you're unmuted, but I still can't hear you. So, Ms. Kukich, in the interest of time, because we do have several scheduled speakers on the agenda, I'm going to close this public comment period, but we will circle back to you as Dr. Pratt said, we will circle back to you at the end of the meeting. You may wish to use one of the call-in numbers that was on your WebEx invitation to be able to call in and be able to speak if your audio is still not working. Okay?
This is Lance. I'm also signed up to speak.
Okay, 1 second, sir. Okay, let's see. I do not see you in our list of speakers who signed up, sir, but if you would like to speak, Dr. Pratt, do we have time for a 2-minute comment period?
I think we should proceed with him since Ms. Kukic was not able to get in.
Okay, that sounds great. So 1 second, let me get the timer back up on the screen. Whenever you're ready, sir.
This is Lionel DeCure, and I'd like to make a statement. I am a member of Dignity for Age, but I'm speaking for our loved ones, our former teachers, our former veterans, our former law enforcement and firemen, our church members, our neighbors, etc., who are in our Virginia nursing homes and assisted living facilities. They are at this very second while I am talking do not have the help they need to get their briefs changed or to help feed themselves. I am 81 years of age, and I never know that I would have to be the one to tell those that should know that our seniors are in dire need. I can't believe that those that should know did not even know that Virginia is ranked 36 out of our 50 states. Virginia got a ranking of D as far as their report card. Virginia nursing home residents continue to have a difficult time getting much needed help from caregivers. Residents receive fewer than 2 hours and 17 minutes of direct care per day. I say again, residents receive fewer than 2 hours and 17 minutes of direct care per day. Virginia nursing home care ranks next to the bottom in the Mid-Atlantic region, narrowly beating out Pennsylvania as the region's worst nursing home state. I was born 81 years ago. I am well aware of the lobbyists working for the giant corporations and their investors that own nursing homes. Some don't want our staff to resident ratios because it cuts into their profits. Some want government aid, others want tax breaks, and many want protection against lawsuits. That's up to me because I just want to be our residents to be cared for. I'll sleep good tonight. I hope others will, but
All right, thank you, sir. With that being said, that wraps up our public comment period for now. We will try to circle back with Ms. Kukic at the end of the meeting, and hopefully we can get her on for her public comment period. But Dr. Pratt, that does conclude the public comment period for now.
Thank you, Ms. Allen. We're now privileged to have a presentation about Claude Moore Scholars from Dr. Bill Hazel at the Claude Moore Charitable Foundation. Dr. Hazel?
Thank you, Dr. Pratt. Good to hear your voice, and I understand a lot of familiar faces are on the phone. I wanted to just start by letting everybody know that upon parole from my state job in 2018, I was at George Mason for 2 years. Then on April 1st of this year, I joined the Claude Moore Charitable Foundation. The Claude Moore Foundation is a private foundation, has been in existence since around 1990, and recently has grown a bit. The featured program has been a program designed to interest youth in healthcare careers and be sure that during high school they get the credentials that are required to allow them to be certificate ready or job ready. And pertinent to this conversation, a number are in the nursing tracks, both CNA and LPN. Unfortunately, spaces and funding from our standpoint has been limited, but with that, this past year we were in 17 localities, and this next year we're funded in 23. But we have a statewide project that we are working on along with a number of colleagues around the state that I want to introduce to you. Now, my question for Rebecca is, how do I advance the slides, or do you do that?
So what I'm going to do is I'm going to give you presenter privileges.
Thank you.
So I'm going to give them to you now, and then the controls are on the left-hand side of the screen.
All right. If I can find them.
Yes, there you go.
Introduce you to our healthcare workforce program, and we have been involved in this since 2007. This particular program, it started in Loudon. It was drafted on the back of a napkin, but again, the idea is to interest youth early in the high school years in careers in healthcare. Hopefully, at the completion of high school, they can have a certificate or be ready for higher education. But as we have learned from this and learned from the challenges that we've had, there is a limit to what we can do at that level. And we are thinking in terms now of encouraging the state to develop a healthcare workforce pipeline. And I'll come back to that. From the standpoint of the Claude Moore program, we do provide funding to not-for-profit organizations which support higher education, i.e. community colleges for the most part, in public schools. And the use of funds is varied, as you can see across the bottom. To give you an example, that we funded a project to get started in Petersburg last year. We wanted them to be able to ensure that they were educating their students properly. Turns out that they didn't even have a functioning science lab, so we've allowed our funding to be used to build the lab this year, and hopefully we'll get into the coursework this next year. As mentioned, we currently support 23 school systems through 7 grant sites. Right now, over time, 5,900 students have participated and over 1,000 have industry certification or credentials. The challenge has been in part space. As I think many of you know or may not know, the nursing programs at community colleges are oversubscribed now, and they're simply there are blockages to getting qualified people in the programs. So as we looked at our ecosystem, we began to ask ourselves, what is it going to take to open the pipeline up for nursing and for other careers? So going forward, the question is how do we create a healthcare workforce pipeline from getting kids interested early on up through high school, ensure that there is credit transfer to community college and from community college to 4-year, if that's what's needed, and even getting out into late career upskilling or reskilling that's needed. And the experience that the Claude Moore Foundation has had would suggest that we need some combination of philanthropy, working with business and government to get this done. And Virginia has a potential model, which is the Tech Talent Pipeline. I don't know how many of you all have followed the Amazon adventures in Virginia, but we had this nice shiny ball of new employment, right? And that created the opportunity for the General Assembly to fund Pathways, a long-term program to increase the number of people to service the tech industry. And why can't we think about the health workforce in the same way? These are some national workforce statistics. These were put together by Tammy Jones and Dr. P.J. Maddox at George Mason. And you can see the certified nursing assistant issue, significant employment needs around the country. Virginia is no exception. And you can't fill positions with people who don't exist, who are not trained to do the work. And we also can't compete effectively for people to do the work if we can't pay them enough. And so these are things that we need to think about. But our programs have encouraged everything from EMTs to lab techs to LPNs and over time. And our hope is to grow this around the state. A few points about the Amazon Tech Talent Pipeline. If you don't know, they're talking about 31,000 graduates over 20 years, 11 universities, $1 billion in funding. And think about this as an investment as people move into jobs that by and large pay better, they pay their taxes, and much of this I think can be recouped over time, but we need to think in terms of a program that is effective and efficient. These are the steps in the Tech Talent Pipeline. You need both students interested and teachers at the K-12 level. I think when you start looking at nursing programs in particular, you need experiential learning. Your employers have to be engaged early on. We need to think about how credits transfer. We have found that a number of our students get credits in high school that could work in community college, but the credits are not transferred for one reason or another. And this needs to be tended to. Finding faculty is a huge issue. If someone in many fields is qualified to teach, they might be able to teach at community college, but can't teach in high school because of the requirements on teaching. And we need to think through that both from a professional and occupational licensing perspective and a teaching perspective. These folks that need to teach these specialties don't necessarily, they aren't going to be homeroom teachers with kids all day. And we need to be able to get that, make it affordable for them to get into the classroom. And I think we can use this as a template to move up the pipeline. So what would a health workforce pipeline look like? Early exposure, camps, programs for kids in middle school, getting an opportunity to have good programs and teaching in the high school level that go towards something that builds a certificate. Even if you don't plan to stay in that field that requires a certificate for a career, it gives a place to start. And as we've gone through, we've talked to people who've had used their certificates to have jobs, and they worked in college at jobs caring for folks as opposed to bartending and other things that college students do. So it works. Think about stackable credentials. Think about how we can work with our professional groups to ensure that that CNA can become an LPN that can get an associate's degree and can move up the pipeline at their own pace and perhaps earning a living while they're doing it and perhaps having their employer help with that. Think about how we can use virtual learning more effectively to compensate for the lack of teachers and around. Think about how virtual learning can help with the experience. It can be difficult and expensive to set up the simulation labs that are required. Then we have to think about professional and career development and even mentorship. Now, there are programs there today. The Area Health Economic Consortium centers are around Virginia. We have the Governor's G3 program that could perhaps play a role in this. Virginia Ready is an initiative to support unemployed and displaced workers coming back into the workforce. Go Virginia Economic Development Initiative might be willing to help fund the creation of a workforce that's going to stay at home and work in existing industries and earn salaries and keep people closer to home. Community college has a health accelerator that a nursing home facility has, MFA has partnered in to help expand the number of nursing slots. So we need business. And then we're working on a pilot in Roanoke right now with 4 nursing home systems, a Carilion, the Virginia Western Community College, and the local high school districts to create a pilot for what might work in this area. I will point out these healthcare education career pathways exist in many areas. You can see them here from Pathway 1, non-clinical workers, to some Pathway 2 GED, license and certificate, all the way to associate's degree and on up. And there, I think, are ways, in many cases, the career and technical education folks have already defined career pathways. But they need to be implemented. Students need to be aware of them. The speaker who spoke earlier about not knowing these jobs exist has hit one of the key points. Now, we have found in the experience, we have hired Deloitte to help with some investigation of how we can improve our program, and that might be instructive for the rest of you. We also have 2 programs with George Mason. One is to work a better data collection system with the Department of Education to understand the outcomes. And then a third program is to think about how we can provide more effective and efficient teaching. but we are seeing, particularly in the COVID area, increasing demand for online instruction. There is some concern about the loss of opportunity in K-12 right now. The digital infrastructure challenges exist. They're real, particularly for lower groups with resource challenges. We are seeing increasing community college enrollment and increasing interest in dual enrollment, i.e. high school students getting credit for community college. Unfortunately, that's not working well. There's no consistent policy for how that's paid for in the state, and how the credits flow, and how the curriculum is designed. And we also can see on the other end, like the George Mason Advanced Program, where community colleges can work with the four-year institution to be sure that all credits will roll into the proposed course of study in the four-year institution. These are evident opportunities to save some time and money. I think that we are looking at a lot of uncertainty in education right now, but we do know that the kids are going to get high school educations, and we need to get them prepared. Some of the roles of stakeholders, it's not just the local and state government. We see the things that they pay for, but we can't do this without employer engagement, and we have to have it set so that employers can bring our students in for experience. With COVID, it meant that many kids could not go to nursing homes to learn. We know of at least one nursing home that actually made them employees so that they could get in and get the experiences they needed. So those are opportunities we need to think about, and I think those may need to be governed regionally. We at Claude Moore are not able to shoulder this burden alone financially, and there are many things that we can help with, and we are reaching out to other philanthropy around the state, the Conversion Foundations and others, in an effort to try to help start some of these programs up. And it's the local organization, what's needed locally, getting the relationships between the schools, the community colleges, and the employers, addressing things like transportation become a challenge in the pipeline. The kids that often would have these jobs are not able to get to the places where they need to be. So many things to consider as you go through the work here. But we would offer you this vision for a healthcare workforce pipeline. Think about 122,000 new jobs. I believe that's as many as in the tech talent pipeline over a shorter period of time, or more than that. Think about the things that need to be organized to make this work most effectively and efficiently. And we are committed to work with you and General Assembly to try to get this concept at least discussed and to make some progress in this area. And with that, Dr. Pratt and Rebecca Allen, I'm happy to take questions if there are any, or as often the case was, is just listen to comments.
Thank you, Dr. Hazel, for a very helpful presentation. Rebecca, are you able to recognize folks who need to ask questions of Dr. Hazel?
This is Sam Kukich. Can you hear me? Hello?
Yes, we can hear you. Sorry, I had myself muted.
Oh, good. I'm on another computer, so it works. I guess I have a question for you, sir. How could CNAs in general, like right now, this sounds like a great plan, but it sounds like it's going to take a long time to make it the norm. So how could CNAs in general be helped with one of your grants, or how would they be invited? What could you do currently for CNAs?
Yeah, I think a couple of things. First of all, you are right. We're looking at it. There are two prongs. One is a long-term solution, putting a Band-Aid on it now and then walking away without a program that has sustainability isn't going to be particularly helpful in the long term. So the approach that Claude Moore has taken, they've been working on this for a long time, but the approach that they're taking is to try to set something up that will work on a sustainable basis. A couple of things. Number one is it is not that hard to get the certificate. So if for short-term staffing at CNA level, people need to be aware of the program. The training needs to be made available, and the extent experiences are needed, you have to get those. And that, I think, can be done in communities fairly quickly to begin to ramp up the numbers. But I think for people to go in, I had heard some feedback from one district where someone went and said, we want to do a CNA program, and this was an area where equity was a concern, and they said, well, you think all we can do is be a CNA? That's not right. We need careers too that are beyond that. So you need to think in terms of how it stacks, and a CNA can turn into an LPN or an RN or take some other branch. I think if you're going to encourage young people to go in on a longer term basis. And then, Sam, I think it's obvious that we need to think in terms of the Medicaid funding. And there's no question that taxpayer dollars do pay for nursing homes for the majority of people, and that when the rates are not there, it is hard to afford the salaries that would keep people in these positions for long periods of time. So those are a few things that I think you could look at immediately.
Dr. Sorry.
I just had a follow on with that. So I think what you're talking about is retention, which is what we were talking about today too. What would you, how would you incorporate that?
From the standpoint of the Claude Moore program, what we realized is that our little piece of it is helping get it started, but there's so much more here to be effective. So I think that we have to think about retention as part of the pipeline. And truthfully, we've been focused on getting people into it. But good management, funding for staff and things always makes a difference in retention.
Dr. Hazel, Melissa Andrews from Leading Age Virginia. I want to thank you for this presentation and just mention two things. One, we received CMP funds with Blue Ridge Community College and Sunnyside Communities in Harrisonburg to create an advanced CNA curriculum. So we're working on that step between CNA and LPN, and that will conclude this time next year, and then we'll be able to roll, the curriculum's already been approved by the Board of Nursing, and then we'll be able to roll that out through community colleges around the Commonwealth. So I'll look to work with you perhaps on how we can get that into as many community colleges as possible, and it does address mentoring. That's a very big piece of it. The second thing I just wanted to mention is we, with our partners nationally, developed a poster curriculum for middle school students to not just address the clinical side of working in long-term care, but also all the positions. So technology, administrator, things like that. So that might be something that we could look at together and roll that into your efforts on just raising awareness. This is definitely a marathon, not a sprint, although I recognize the short-term needs, but those are just two ideas that we could potentially collaborate with the Claude Moore Foundation on. Thank you.
Melissa, that's terrific. We can, if you could get my contact information, we are trying to improve our program and do some outreach, and that's what got us in touch with the senator and the invitation to present today. A lot of experience, and I can tell you that we're working over in the Luray area right now. I think we are paying to put a sim lab in the community college. I think it's Lord Fairfax over there. So, there are many opportunities. I look forward to getting your material.
Great, thank you.
Great.
Are there other questions, for Dr. Hazel? Thank you very much.
Thank you very
Your
much.
slides have given us a lot to think about, and we appreciate your taking your time to be with us. Of course, you're welcome to stay through the entire meeting and visit back with us anytime you like. Dr. Hazel, thank you so much.
Pratt, good to hear your voice.
Same, sir.
Same, sir.
Our next presentation is from the Department of Medical Assistant Services. We have two presentations from them, and Barbara Seymour is going to make those introductions at this time.
Sonia Austin.
Try again, Ms. Seymour.
Okay. Sonia Lee Austin, who is under the leadership of William Lassard. And she is a healthcare reimbursement manager. She is going to be addressing the rate setting. And then Evelyn Hardwick, who is under the leadership of Tim Kasserman as manager, and Terry Smith as our division director for the Division of Aging and Disabled, which is the division that I belong to. So Tim is going to introduce Evelyn a little bit more, with a little bit more detail, but Sonia should be ready to present.
Hello, this is Sonia.
Hi, this is Rebecca Allen. Would you prefer to advance your own slides, or would you like me to do that for you?
Whatever is easier.
Okay. I'm going to give you, well, if I can, I'm going to give you a presenter credentials, so just give it a second. Okay, so if you take your mouse all the way to the far left-hand side of the screen, you'll see like a long, oblong white lozenge pop up, and in the middle there's like 22. Do you see that?
Oh, yeah.
Yes. Okay. So the arrows up and down will advance the slides for you.
Oh, there we go. Okay. All right. So my name is Sonia Lee Austin. I'm relatively new to the position of Provider Reimbursement Manager under William Lassard in the Provider Reimbursement Division. Sarah Benoit is our nursing facility subject matter expert, helped me develop this presentation. You may have been familiar with Beth Jones. She has moved on to working for CMS now. So we'll just give you a high-level overview of nursing facility rate setting and where, in terms of Medicaid program and where the funds come from. So here you can see the majority of funding on the left-hand side is now under managed care, with over $200 million a quarter being dedicated to nursing facilities. And these are the expenditures that the managed care organizations pay to the nursing facilities from encounters. This is covered by the Commonwealth Care Coordinated Plus, or CCC Plus, long-term care managed care program. The managed care organizations are required to use the fee-for-service nursing facility rates as a minimum fee schedule, but they are not necessarily required to pay a per diem. They may use like a shared savings arrangement or have additional incentive programs that are not on the fee-for-service side. And then on the right-hand side here, we show the general breakout of where the funds for Medicaid come from. About half is from the federal government, something called FFP, Federal Financial Participation. States must, on the fee-for-service side, submit state plans and update them regularly with a state plan amendment to have their payment arrangements approved by the federal government, CMS. The state share comes from the state funds. And the Federal Register often gives direction in terms of Medicaid reimbursement, but also the state plan amendments often are very similar, if not exactly the same language as the Virginia regulation language about reimbursement. Here in the title page, the main reimbursement regulation is the Administrative Code, Title 12, Agency 30, Chapter 90, has kind of the high-level overview of the methodology that the agency is required to establish rates according to, and this can be updated by the budget as it is accepted. So anytime rates are established, the regulations and any budget amendments are gathered and the data sources are gathered, and then calculations are applied. So generally this means annually there is inflation from Global Insight, and then every 3 years the rates are rebased based on the nursing facility cost report. And then that is kind of generally where the rates come from. And the nursing facilities are split out into peer groups to try to get a better allocation of funds to places that have higher cost of living, like urban versus rural. There are also some adjustments for bed size on the indirect side. The data sources that are gathered include primarily the cost report data, but there is also patient acuity, severity of illness data that comes from the minimum data set, which is a questionnaire that you may be familiar with that determines the activities of daily living that a member needs and if they need therapy, and is very detailed. It's a CMS questionnaire. And then the inflation comes from the company that took over Global Insight. So the grouper software takes the patient acuity data from the management, the minimum data set, the MDS, and groups it into resource utilization groups, which are clinical categories. And there's also some managed care data and fee-for-service data outside of the cost reports, but the primary source is the cost reports, which are primarily fee-for-service based at this time. And then the peer groupings are determined based on the wage indexes and urban versus rural, and determined also by just bed size on the indirect. So here we have the basic formula simplified down of all the different rate components. So direct cost, this is the nursing cost. LPN, RN, CNA, it makes almost 50% of the rate. And that comes directly from the cost report. And then indirect costs include like dietary, housekeeping. That's almost, not quite, the other half. And then capital is at roughly 10%, so all of your overhead and building expenses. And then nurse aid training, some facilities have it and some don't, but it's under 1%. And same for criminal records check, part of the rate as well. The direct operating costs in the formula at the bottom is adjusted by the, what they call the case mix, the RUG case mix from the MDS. So if a facility is having more severe patients than others in terms of what their diagnoses are, the RUG adjustment will increase their rate. And then once you've made that adjustment, then the indirect operating capital and the other ancillary adjustments are added on. And this, the RUG case mix neutralizes the base rate based on the facility's overall like costs, but each member gets a separate case mix adjustment for their per diem amount. So it is by patient that the per diem rate is calculated. So here's kind of more of a breakdown on some of the RUG categories. These are based on a CMS methodology. Medicare originally used these, so they would have additional categories that were tailored more to Medicare population. And the ADL range in the third column is the activities of daily living. So there are different groupings based on how many activities of daily living a member needs help with. And then the RUG weights in the far column are kind of a ratio of how much kind of that resource use a member needs. So you can see the bottom one is a default group, which someone can fall into, like for missing information or something. And then there's also behavioral, cognitive, and all the way up to more complex needs, which gets a higher number. So like a 3 would be the highest. So this would be your most complex patient. So these scores, the RUG scores in the far right column, are used to adjust the per diem rates that nursing facilities get on the fee-for-service side. And most of the managed care organizations also follow this methodology and use the fee-for-service rate, although they are not required to, only they must use them as a minimum threshold. So the nursing facility website page of CMS has a lot of resources for you if you want additional detail. There's the wage survey that collects hours and wages for employees of the nursing facility. You can see what type of information is collected there on the far right top. And then the green banner below that has the current rates, and the yellow is the RUG weights that are currently active. And then for specialized care, which are the facilities that fit into more specific member criteria, those rates are below that. Those are determined in slightly differently. And then on the left, more about cost reporting and case mix. So that's all I have for today. If you have questions, I'd be happy to answer them.
Thank you. Are there questions for Ms. Lee Austin? Since there seem to be no questions, Ms. Seymour, would you like to introduce the next presentation from DMAS?
Give a little bit of a background on Evelyn and the program, and then Evelyn will present. Are you there, Tim?
Good afternoon.
Evelyn, are you there?
I see that I am unmuted, so I'm assuming you can hear me.
Yes, go ahead.
Very good. Well, good afternoon, Chair Pratt and work group committee members. DMAS is pleased to present to you some information about the CMP program, and I'm excited to hear that some of it has already been talked about with the Blue Ridge group that has a grant. We have several staff working on the CMP project. Our lead on the project is Courtney Richter. Unfortunately, she couldn't be with us today. She delivered a child a couple weeks ago, and so she's on maternity leave. So in her place, we have Evelyn Hardwick, who has been working with the program. We are pleased to have Evelyn join our staff this spring, and she comes to us from working for 17 years with VDH, so she is very knowledgeable of VDH and now DMAS, having been here twice, and we're glad to have her on board, and I'll turn it over to Evelyn for the presentation.
Hello.
Okay, Evelyn, you're
I'm
muted.
Evelyn. Okay, and I'm looking for my slides. Do you have them, Rebecca?
I do. Do you want me to advance them for you? Or would you like the control?
I can do
Either
it if that works for you.
Sure, just
I
one
don't have to
second.
change from what we spoke of, but
That's all right. Okay, so if you take your mouse and pull it all the way over to the left-hand side of the WebEx screen, you'll see a little long white lozenge pop up that has a number in the middle of it that says 31 right now.
yes.
Yes, and so the arrows above and below it will will allow you to advance the slides.
Okay. There we go.
There you go.
Okay. Mine, as I was introduced, is Evelyn Hardwick, and I'm working with the Civil Monetary Penalty Project and funds through the Department of Medical Assistance Services. I'll give you a brief overview of some of the projects and explain what it is and go through the cycle, and then give some examples of current projects that the department currently has working. The CMP, oh, now I'm missing my ear. There it goes. CMP fund is a collection of monetary penalties that CMS imposes against nursing facilities when they are not in compliance. And these are penalties that CMS imposes against the nursing facilities. They come as a result from the surveys that are conducted through the Department of Health, and CMS imposes these fines. And then the CMP funds must be used to directly benefit individuals residing in the nursing facility. So quick and easy, there's a problem at one of the facilities, CMS would come in and fine them. Once the fines are paid, they set money for these projects to go directly back to helping the nursing facilities. Virginia has some of the most projects, more projects than any other state currently.
Stop.
I'm sorry?
Sorry.
Okay, and the projects come in and we do an annual cycle. Before I get to the annual cycle, I'm sorry, I'm getting ahead of myself. The projects are codified, not the projects, but the CMP penalty funds for improving the life are approved by CMS. The big thing to remember is that in Virginia, the General Assembly appropriates the funds and determines how much the Department of Medical Assistance Services can use for the CMP funds. And then the projects and everything is approved by CMS. The CMS is the final arbiter of all our projects. And we have to report all the projects annually to the General Assembly on the basis of the use of funds. The projects all have general outlines and requirements. They're not to exceed 3 years. Again, direct improvement of the quality of care, and just for helping the consumers and the families, providing training, as we talked about. So these are, and culture change, these are just some of the different topics that the projects can encounter. We also do have to have, in addition to the projects that we work on, a fund of money has to be held for emergency funds. If, for instance, residents need to be transferred out of the locality, out of a facility into a different facility due to problems with the care. And the projects, again, they're not just supplant the facility's requirements, like for instance, health and safety, but they're to make it stronger. We're not replacing anything, but just to make it work on the health and safety and increase it. Again, with grants, and there's specific prohibited uses that are listed into the that are not allowed. And this is, you can't make capital improvement, use these funds to make capital improvements to a facility or to increase a staff member's pay. And so these are just some of the different things you can't do, and that's all outlined in the legislation. The application process starts, for instance, in January of the year, we issue the RFA and a Medicaid bulletin trying to recruit and solicit projects to apply for use of these funds. And they submit cover sheets, and then a month later, the applications come in, and all of this is reviewed and looked at by DNAS. We request additional information concerning the grant and the objectives and subject matter that is being approved. And then it is sent off to CMS for their review and their approval of the project. And then once the projects are approved through CMS, they come back to the Department of Medical Assistance Services for contracting to make sure we're the overseeing and oversight of the funding and the applicable and the funds that are being used. This year, I'm going to say it over and over again, and we're probably all familiar with it, but COVID-19 pandemic changed the way the CMP projects were working for 2020. With the approval, we were receiving a lot of feedback that it just wasn't going to be possible at this point in venture due to COVID to get into some of the facilities to continue the grants and provide the necessary trainings to staff members to complete the project. So at that point, with the input from some of the leading advocates and others' input, and the blessing of CMS, the process for 2020 has been delayed, but we are holding all applications that were submitted in early 2020 before this was delayed, the cycle was delayed, and we'll hold on to those. And we're also looking and taking note of other parties that express interest in the CMP program. It should be interesting. The CMS issued a news last week that during the pandemic, they've already issued more than $15 million in fines. So that's going to hopefully open up a lot of project opportunities. So at DNAS, we're also going to be looking at, trying to encourage applications for different projects. I'm going to go over some of the different projects that we have ongoing now, which is going to be interesting because many of the individuals probably in the room can probably provide a lot greater detail on some of their projects. as I'm recognizing the names and the projects they've identified. The first project I'm going to discuss is the Person-Centered Trauma-Informed Care Training. And we worked with the VCU School of Gerontology, and it's to provide trauma resilience training. This project has concluded and it was done successfully, but basically part of the idea behind this training is to recognize the trauma, which is broadly defined when external or internal coping methods are overwhelmed, and the resilience, which is the ability to recover from this adversity. So the best way is to communicate between the caregivers and the patients. Just a brief general idea that might help explain this a little bit better is if an individual had trauma, for instance, if they were beaten in the past, and that trauma from the past is causing issues and makes it manifest in a way that they can't work with certain members of staff. So identifying that issue and finding the more appropriate staff member and working through these anxiety traumas can help with a greater sense of trust and safety in the nursing facility for the patients. And as I said, this project was completed. They had, we had 54, well, I didn't, 54 CNAs participated in 9 different training sessions, and 95 different interdisciplinary team members from 21 facilities participated in the training curriculum. At the end of the project, most of them expressed the intent to make change behaviors and service delivery changes to better optimize the care for the facility residents. The Advanced Nurse Aid Revitalization Project for Rockingham County, we've already discussed a little bit briefly earlier this morning. This is a program, as was mentioned, to provide additional skills to improve care and well-being in the nursing facilities. We're providing additional skills for the CNAs. And not only is it to increase the skills, but it also, as we talked on earlier, was mentioned, it creates a career path for an advancement ladder, which ultimately kind of increases staff retention and decreases burnout. Everybody likes the opportunity to be able to move ahead and know there's something in advance with them. The Board of Nursing has approved the curriculum that was suggested, and Blue Ridge Community College, as was mentioned, was to offer the courses. And the class was supposed to start tomorrow, but they were unable to the nursing facilities were unable to send the CNAs to the classes. So that also has been postponed and will be rescheduled at a later date. Another project that we have is the Restorative Sleep Program. And this is contracted through the Riverside Center of Excellence in Aging and Lifelong Health. And it's to create a positive nighttime environment by addressing common sleep disturbances. Just simple things that we should even be applying to our everyday lives, that they're bringing attention to the nighttime environment and disturbances such as noises, lights, no TVs, just general environment settings to promote better sleep. And in the daytime, to also focus on, when are the naps, how does the medications they're taking, patients are taking, or residents are taking, and their diet, and their activity level, how does that work into their sleep cycle? That's working through 2 facilities currently. There's one facility postponing the implementation of the 4th. Well, 3 or 4 workshops have been completed. The 4th one has been delayed along with the implementation of learning these ideas and then putting them into practice. And again, it goes to if you sleep better, you feel better, you're in less pain, you have less inappropriate behavior, and it's more meaningful activities during the day, and everybody just feels better and works better. That's putting it very simply. I'm going to move on to another project that we have. It's reducing preventable hospitalizations. And the purpose of this is through the Virginia Healthcare Association, and it's to work with providing trainers on the Interact 4.0 tools. These tools basically, it's increased communication is the important thing, and reducing rehospitalization. By increasing the communication and early identification, evaluating and managing these things that are identified through these tools is the purpose of reducing the hospitalizations, which ultimately does elevate the quality of care of patients. The Holistic Wellness Project is another project that we're working with. And again, this is providing education and engagement. They're looking to, in use of this Birdsong software, which helps, it's very user-friendly, and it helps the person create the environment they're used to. It works with, working and decreasing the use of medications, antipsychotic medications, result in less falls. And it provides just everyone an environment to grow and learn and work together and have less falls, be happier, which is a great increase in the quality of life. Another program is the Music and Memory Initiative. Again, a lot of these projects, if you think about, as applied to your life, relate to patients and residents in nursing facilities. If you like the music you like and it makes you feel good, you feel better, right? It's not quite that simple, but it does put you in a better mood and you have better focus and level engagement, which also, again, goes to decreasing the antipsychotic medications and anti-anxiety. And this also ultimately, therefore, results in less falls. Again, it's implementing a person-centered, non-pharmacological intervention. And it helps benefit and stimulate different parts of the brain, taps into memories that weren't and haven't been damaged by dementia. So you get that project. The next project is the Virginia Wound Care Excellence Program Certificate for Nursing Facilities. And the title, again, sort of explains this, but it's a focus on wound care, which is a major challenge in nursing facilities. It increases costs and decreases the quality of life. So this project, it was completed this summer, and they had 150 nurses certified in the VOVRA wound care, and the number of residents in a long-term stay residents with pressure ulcers decreased 43% in participating facilities with this program. And then we're going to move along to the peer mentoring program at Westminster Canterbury in Lynchburg. This is the goal is to advance the person's directed living culture by establishing a peer mentor program. You get a greater skills with the staff and the workforce, and improved engagement when you have somebody working with the residents, and it builds trust, and determining what services are needed. The consultants are currently working on curriculum development with this, and then the implementation of the curriculum has been postponed due to, again, COVID-19. And COVID-19 also this spring brought around another temporary initiative, well, a one-time initiative as far as we know, from CMS. This is the Communicative Technology Initiative in response to the COVID-19 and the guidance for infection control and prevention. Each facility could request up to $3,000 in CMP funds to purchase devices and accessories for residents to share to help with telehealth medication visits for doctors that are not internal in the facility, and most to provide social visits and communication avenues with family. So since visits were shut down, everybody could, communicate. The feedback on this has been really good from the facilities that have purchased it. A lot of excitement around this initiative. We approved 195 facilities to use the CMP funds to purchase the communicative technologies. This is just shy, or for a total cost of $491,123. And anything that was above the $3,000 limit was possible, but that would have to be sent again to CMS for their approval. And then they could apply funds. In closing, I just want to just reiterate that CMP funds are allocated by the General Assembly, and they're approved by the CMS. CMS is the final arbiter of all projects and information. Are there any questions that I can answer? Or I'm going to be also urging you to submit any questions to the address that you see on the screen, which is the generic or general email address that will hit everybody that works with the fund, and we can get a better answer out to everybody, because I'm going to be honest that I don't know all the answers. So I'm going to be seeking help on them.
This is
more than willing to work.
Sam Kukic from Dignity. I have a question. With the COVID, it seems like there's a lot of your programs that are not being able to be completed right now, and I understand why. But one of the aspects of COVID is isolation, and I'm wondering if you've come up with any programs or anything to combat the isolation, because people are losing weight and just sitting in a room by themselves every day. So do you have any ideas on programs that you can do that deal with that?
Okay, well, with the isolation, that was a big point and purpose of the communicative technology grants that were issued to provide these tablets or iPads.
Yeah, let me just say this about $3,000 per facility. How many iPads can you buy for that? I mean, and if they're sharing them, then you're worried about transmission of whatever. And I'm just thinking, if people have 120 or at least 100 residents, a few laptops or what do you call it, iPads aren't really going to make it. $3,000 isn't going to buy a lot of them.
Right. Can I just jump in for 1 second? This is Melissa Andrews with Leading Age Virginia, and the Virginia Governor's Conference on Aging is sponsoring a webinar on this very topic next week. So it's on how long-term care providers are addressing social isolation. So Sam, that might be something that you're interested in participating in. It's open to the public. It's free. So anybody who wants to be part of that can go to the Virginia Governor's Conference on Aging website and register. Sorry, Evelyn.
Oh, I appreciate that.
I appreciate it.
I just might have an answer, that's all.
Well, and I was just going to go back to, I understand with the communicative technology grant, $3,000 may not be a lot of iPads or devices, but the facilities work to try to get as many as they could or what worked best for their facility. And all there were several other requirements that I did not hit on, but the devices have to be shared between 7 and 10, one device between 7 and 10 people, our residents. And they had to, most importantly, meet the criteria, the CDC guidelines for, safe infection, not safe infection. Okay, now that was a nerve talking. But for the, and now I've forgotten what I was talking about. No,
infection control.
Thank you. And that is what they were looking for. They had to meet this very strict. And some of the facilities even they had to follow the infection control that CDC provided.
Now, I may comment, though, the problem within so many of the nursing homes is they don't have enough staff to individually take time because they're trying to feed residents. When you have 20, 30, 40 residents with one CNA, there's no time for all of this. That's what I'm hearing from just hundreds and hundreds of CNAs. I'm sorry, there's just not enough time for that.
I had a question kind of surrounding that subject, and I was wondering, Ms. Hardwick, is there any possibility that any of those funds could be actually used to hire CNAs, or is that out of bounds? This is Susan Hines with Dignity.
Yeah. Ms. Hines, to be clear, the DMAS does not come up with the projects and the funding, so we wouldn't be looking and have at this point any authority to hire any additional CNAs or do anything like that. But that might be something that perhaps in the future and next year, if someone could start working on requesting the CMP funds for something around that topic. But when it comes to money and hiring,
I have another suggestion. If you instead of hiring CNAs, if you hire people to work with those laptops, and that would be their job to go around and help the residents, then that wouldn't take away from the CNAs. Then that would be like part of the project.
Well, and those are very interesting points and things. But another thing is, it is hard right now to get individuals into the facilities to provide these trainings or volunteer to help with this. But a lot of this, we provided the grants and the monies, and it's up to the facilities to use their money as they said they would for the supplies and the technology to better the residents' quality of life. And you can always do more and want more, but that was the limitations that was set up for the CMS guidelines for this project initiative.
This is Senator Kiggins. I just have a question about is there still money left over for this communicative technology project, and how much of the money?
The project, we solicited applications in May, and they were supposed to be submitted in May, and all the funds were dispersed in the end of the last fiscal pay in June or the 1st of July of this state fiscal year. Mm-hmm. So as far as funds being available, and as far as I know, that initiative through CMS has closed, and no longer are we accepting applications or any actions on that.
So you sent $491,000. I'm sorry.
This is Tim Kaufman with DMAS, and I'm going to just jump in here. The way the project worked is that the nursing facilities that wanted to applied for funds. So it's not so much that we had a cap on the funds, it's those facilities who wanted to access those funds. So everyone that wanted to access and was eligible to access, we did approve the funding for. And with regard to hiring CNAs, the purpose of the funds are to promote, to benefit the residents and to develop new programs and initiatives that could be used across all nursing facilities or explored across all facilities. So the intent is not to fund the ongoing operations of the facility. That's done through the process that Sonia described with the reimbursement methodology. This is for new initiatives to look at exciting opportunities. And with the new grant cycle opening up in January, we anticipate a whole different caliber of grant applications based upon what is gleaned from the COVID experience.
So this is Senator Higgins again. I just want to understand this correctly. So the application cycle opens in January and it's in the form of a grant. So the place who has the idea would apply for this grant, and then and anyone can apply, and then they find out when, and then when do they actually get the money?
When the grants and the contracts are finalized, which typically happens in July, that is when, and the contract that they have lays out when the money is received by the project. It can be laid out, like I said, they can't go longer than 3 years, and we require, the projects submit invoices to the Department of Medical Assistance Services for reimbursement of the funds and repayment of the funds through the CMP program. I don't know if that helps explain.
Thank you.
Okay.
Any other questions?
Well, again, if there's anything else or you come up with anything, please just address it to the email cmpf or cmpfunds@dmas.virginia.gov, and we will definitely get an answer and get back to you. I hope this provided some information that was useful to you this afternoon.
Thank you to both presenters and to DMAS for making this important information available to all of us today. We really appreciate it, and we have your contact information if we want to ask you further questions. Thank you for your time and for the presentation. The next presentation is from Megan Green at the Chief Workforce, Office of the Chief Workforce Advisor. Ms. Green.
I am on. Hi, how are you doing? Can you hear me?
Yes, good. Doing well.
How are you?
Okay, great. And I'm happy to present on my own if you can give me access to the PowerPoint.
Yes, 1 second. Okay, so you should have presenter privileges now. So again, if you take your mouse to the far left-hand side of the screen, yep, there you go.
There we go. Okay, thank you very much, Dr. Pratt, Rebecca, for inviting me to present today. My name is Megan Green, and I work in the Office of the Chief Workforce Advisor to Governor Northam. That's Dr. Megan Healy. So the other Megan, I always feel like I have to stress that I'm not the Chief Workforce Advisor, but it can get confusing with us both having the same name. I also will say I've had some connectivity issues on this call, so I'm going to refrain from using my video because I don't want to get kicked off. Hopefully that's okay. So can you all see, is the presentation showing up all right? It's a little skewed on my screen. Okay, perfect.
Yeah.
So today I'm just going to talk a little bit about the workforce programs that relate most closely to this issue of clinical workforce in nursing homes, the ones we interact with most often. I'm going to cover a couple new programs and initiatives that emerged specifically in response to the COVID-19 crisis. And I'm also going to touch a little bit on, I think, lessons learned from this pandemic that might sort of inform our approach to this issue of clinical workforce and shortages in nursing homes and in long-term care. this issue of shortages in nursing homes and healthcare in general was an issue before the pandemic. I know you all are very aware of that, and it'll be an issue long after, but I think there's some information, lessons learned that we can use to kind of think about this differently potentially. So starting out with something I'm sure you all know, this is just some numbers we have on employment growth in long-term care facilities. You can see it's very positive over the next couple of years, and each color here represents a region, and we've got positive projected employment growth across all regions of the Commonwealth in this area of long-term care. Here you can see a list of occupations in long-term care. This list of occupations makes up about 80%, and you can see CNAs are a majority, almost 20,000 in 2019 and in 2020, but there's positive projected employment growth for all of these occupations. And then to the far right, you can see median hourly earnings, everything from $9.50 an hour for personal care aides to almost $50 for medical and health services managers, $33 for RNs. So that's nothing new, just providing an overview of the data that's relevant to our discussion. Kind of building on that, I want to introduce some data that touches on the influence that COVID-19 might have on this picture. This is a really interesting analysis that was done for us by the Virginia Economic Development Partnership in response to the question, who will most likely need to be reemployed or might not return to the same employer after COVID-19. And you can see the industry sectors that they identified are accommodation and food services, retail trade, and administrative and support waste management remediation. And this tracks pretty closely with what we saw during the Great Recession and economic downturns in general. These industries tend to offer a little bit less job stability, less labor market stability for workers. And so, digging a little bit deeper into the occupations in those industries, we can see accommodation and food services, retail trade, administrative waste remediation. You can, in accommodation and food services, you see combined food prep, serving workers, waiters and waitresses, cashiers, retail salespersons. And these occupations were identified, number one, because they account for a large percentage of the total jobs in those three industries that I identified. Serving workers, almost 22%. But you'll also see that these occupations have no formal educational credential, minimal short-term on-the-job training. These are generally low-wage, low-skilled positions. They don't offer a lot of upward mobility, and like I said, they don't offer a lot of job stability. So for that reason, we're kind of thinking about how these occupations are a prime target for retraining. And in the context of long-term care, we need to think about how can we, recruit and retain these individuals into the clinical workforce, and at the same time think about what might be preventing them from making that move into a job that does have a lot of benefits and can provide greater job stability. One group that's kind of working to answer some of these questions that I want to mention is the Governor's Virginia Healthcare Workforce Advisory Council, which is chaired by Dr. Healy. And this group is made up of healthcare stakeholders, health systems, higher education, certain relevant state agencies, with the goal of developing policy recommendations that can help to address these Virginia's future healthcare workforce needs. At this point in the work plan of the council, we are working on interviewing different members, and I can say that shortages of CNAs, general workforce shortages is a very much a recurring theme in those conversations with the council members. So this is something that hopefully some findings and recommendations can emerge from down the road. So going back to the question of how do we bring these positions, these essentially what we would call dislocated workers, people who have had the unfortunate experience of losing their job, that might not have a job to return to, how can we direct them into the clinical workforce in nursing homes? And I'm going to address kind of three pieces of that puzzle. I think the first one that you really can't ignore, and that's been mentioned many times on this call and on previous calls for this work group, is the wage issue. If you look to the left, you can see some of those occupations in long-term care. Nursing assistants making up over a third of that population, they make $13 an hour. And, in some of these supervision roles in retail, you can make a lot more than that. So sometimes you can make more at Target than you can make as a CNA in a nursing home, despite all the additional challenges that go along with being a CNA. And so, you know, we know according to MIT, a living wage in Virginia is about $14 an hour. And so you can see some of these food service or retail jobs, they pay that. They allow people to have a living wage for their families, and some of these long-term care positions don't. So that's definitely something we have to think about. How can we help raise these wages? And, you know, maybe providing additional funding to nursing home providers or addressing the underfunding of Medicaid. That's definitely has to be a part of the conversation. Kind of the next piece of that, I think, is training, because if you think about someone who has a history of working in retail, that doesn't require any training, as I mentioned. And there is a little bit of training, no matter how minimal, to be a CNA, or even if you want to continue, obviously a lot more training required. So that's an important piece. How can we make training into the clinical workforce as accessible and affordable as possible? So I want to highlight two things here that Virginia has to support job seekers. We've got the Virginia Career Works system. And for those of you who aren't familiar with this, it's a network of over 60 locally based career centers that are intended to provide a one-stop shop, a front door to the workforce system for businesses and job seekers. So businesses can come, and this includes, you know, hospital, private employers, can come and get services to connect with job seekers with certain skills. They can get help with job fairs, virtual hiring, and job seekers can come in and get assistance writing everything from writing your resume to applying to a job on the Virginia Workforce Connection, to thinking through what their skills are, what they're most interested in, and getting connected to training and education that can get them down that career path that they're most excited about. Kind of building on that, one of the pieces of training that an individual will learn about if they were to go into one of our career work centers is the Fast Forward program. And this is a fully state-funded short-term workforce credential program, and it's designed to train Virginians for jobs that are in demand, and those in-demand jobs are determined by the Virginia Board of Workforce Development, which every year goes through and identifies according to different metrics what the most high-demand jobs are. And it trains Virginians for those jobs by subsidizing a credential in one of the fields. So it's a pay-for-performance model where the students pay 1/3 of the cost of the training. It's an average of about $1,000. The institution, this is a partnership with the Virginia Community College System. It's administered by VCCS. The respective institution will cover the second third of the cost of the program. And then if the student is able to progress all the way through and achieve that credential, then the institution will cover the final third. So this is a fantastic program. The average age of someone enrolled in it is about 36, so it's really great for adult learners. And it's built around the idea that a lot of adult learners, the average time for this kind of credential is 6 to 12 weeks. So it's the idea that the reality in the workforce today is people they can't always afford to go to school full time. They want to get in, they want to get out, they want to get those skills to start making money. But these jobs, these high demand jobs, because they are so high demand, really do offer a lot of job stability. And you know, we know that the training that they're getting is going to be in jobs that are going to be around in the next 10 years. So in the healthcare credential space, there are training available for pharmacy technicians, clinical and registered medical assistants, medications aides, and of course, certified nursing assistants. So it's really a win-win for everyone. The job seekers get to get this subsidized credential, and the employers get to benefit from, you know, an increased applicant pool, better trained workforce. Okay, moving on. So a program that emerged in specific response to the COVID-19 pandemic is the Virginia Ready Scholars Program. And this builds on the Fast Forward program by offering what's called Virginia Ready Scholars, or individuals that want to go through the Fast Forward program, with a $1,000 Credential Achievement Award at the end of the program. And so it's kind of covering that $1,000 that they would initially have to front, with the understanding that particularly during this crisis, it's very difficult for a dislocated worker even to come up with $1,000. So it also, I think the public-private partnership piece of this is one of the things that makes it exciting. Virginia Ready is a partnership with about 20 large employers: Bon Secours, Centera, Carilion Clinic, the Virginia Community College System, Fast Forward. And so Virginia Ready Scholars have the opportunity to interview with some of those Virginia companies in the field where they're receiving the training. So this is It also kind of includes a component of establishing that relationship between the educational system and those employers to give them the opportunity to connect with a community college to make sure that those training programs are industry driven and aligned with their needs. Okay, so then kind of continuing on with that training piece, another thing that I definitely wanted to mention, and this is still very much in flux, so I don't have as much information on it as I would like, but I can give you sort of the introductory overview of the National Dislocated Worker Grant that the Virginia Community College System was awarded at the federal level, $3.3 million, to deploy 2 healthcare aid education programs, of the majority of the training online, which is, perfectly suited to the situation that we are in. So a portion of this funding is going to be directed specifically towards employment and training services for dislocated workers, and it's going to help to subsidize training for, things that are disaster specific, like temperature takers, but also for training for CNAs, home health aides, personal care aides, pharmacy technicians, positions like that. And one of the stated goals in the grant application for this program was, not only to close the immediate healthcare workforce gap during the COVID crisis, but also to result in continued employment post-pandemic, and for this to be a kind of, one piece in the puzzle of addressing healthcare workforce shortages more broadly. Moving to kind of the third piece of this discussion is the idea of career pathways, and this has been mentioned many times. One of the things, not only wages, not only the cost of training and accessibility of training, but when someone's thinking about, if a dislocated worker is thinking about making that transition into another career, they're going to be thinking about the upward mobility that that career offers. And is this going to, especially if we can't, move the needle on those wages, people understand, can I take this low wage job and is it going to get me somewhere farther in the future? And can I move down a career path that's going to allow me to provide for my family and to, give me greater opportunity? And so I think, we need to think about how to make that clear, how to make it easy, and understanding, again, the reality of adult learners is that they don't often have the money to go back to school. They can't go all the way through an associate's degree or all the way through a bachelor's program. Sometimes they need to go in and out and work and go to school and come back. So it needs to be more flexible. So I wanted to highlight the G3 program, which Dr. Hazel mentioned, which is a proposed free community college tuition program for low to middle income families. And these are for students that are specifically seeking employment in a high demand sector, of which healthcare is one. So this program builds on a recent redesign of the community college level. I think it was last year, the year before, definitely before my time, that offers kind of a stackable model that lets students move up the pay scale in their careers while furthering their education. So you can see to the right, there's this model of, you've got your level 1 job, maybe that is a CNA, maybe you have that CNA training or that advanced CNA training, and you're going in, you're starting your degree, you're getting basic skills on day 1, you're not necessarily starting with your general education requirements. You're kind of moving through, you go to level 2, maybe you hop off and get a level 2 job, maybe you continue and then get a level 3 job. It's just being really cognizant of the realities of particularly adult learners. So I think the question is, and this is a proposed program, it was funded by the General Assembly in the last session, but obviously funding has been put on hold for this given the crisis. But I think that the conversation more broadly is one that many of you have mentioned, is how can we tailor this for the clinical workforce in nursing homes? How can we make a CNA position, for example, a launch pad for something that pays more down the road, and kind of raise awareness about the fact that it does offer a lot of job stability even at that level. So then really quickly, I just wanted to touch on the retention piece, since I know that's definitely been a focus. So we know in our conversations with long-term care providers and just in the healthcare space in general that employers have been trying a lot of different things to retain their employees during the crisis. Things like pay increases, hazard pay, stipends for transportation or for childcare, connections to childcare, peer mentoring programs, which research shows can really help workers deal with, feelings of isolation that can come along with careers in a nursing home, challenges in the job, problem solving, just kind of navigating that, and also a career path with education, opportunities for career advancement that employers can help to subsidize, building off of the Fast Forward program and other things that exist. And so I think I just kind of wanted to make the point that these innovative solutions are ones that we can also consider long term. How can we make this a part of the model and encourage employers to implement these best practices, given sort of their efficacy during the crisis? So that is my overview. I'm happy to take any questions. I know that was a lot of information.
Other questions for Green? Thank you, and I'd like to point out to everybody that this information is available to you. I know there's a lot in each one of these presentations, and this is available to you online. So if you care to go back and understand more about this, please do. Our next.
Carol, you're muted, I think.
Our next presentation is from the Virginia Healthcare Association and the Virginia Center for Assisted Living. Mr. Keith Hare, are you ready?
I am ready. How are you, Dr. Pratt?
Good afternoon.
Rebecca, if you don't mind, I think I had mentioned to you that I could do my own slides. I'm going to go back on that. And if you don't mind, do you have them, or do I need to pull them up?
All right. Can you see them, sir?
Cannot.
On the screen?
No, I just see Megan's.
One second. Let me reclaim the host, or not the host role, the presenter role.
Sorry about that. Oh,
That's
let's
right.
swap that one. That'll scare everybody.
Can you see it now?
Yeah, I can. And you can go ahead.
All right.
You can go ahead to the next slide. Just for those on the phone, one, I want to thank Dr. Pratt and Senator Kiggins for their work on this issue. Rebecca, you've also been, tremendous to work with. I also want to take a second to thank the family members of those who have loved ones in long-term care facilities that are represented on the group. That is a critically important component to have as a part of this discussion. And so I just, welcome your comments as we move through this process. We were asked to just kind of give an overview of, nursing homes in Virginia. And if she's still on, I do want to take a second to recognize my counterpart with Leading Age Virginia, Melissa Andrews. I think between both associations, we represent every nursing home, and sometimes they get represented twice because we have dual members. We also have a number of assisted living providers, but you can see, I'm not a big fan of reading everything that's on a slide, but we do represent 92 assisted living facilities with about 6,000 beds. I believe there are a little over 600 or so assisted living providers in the state, and that varies greatly from where you would have 5 beds in a facility to hundreds of beds in a facility, but they're all regulated by the Department of Social Service, whereas the nursing home beds are regulated by the federal government, and also that's by and large carried out by the Virginia Department of Health Office of Licensure and Certification. And then just a breakdown of our membership, which is really indicative of what you see across the Commonwealth is, we have not-for-profit members. We have actually government-operated centers in Virginia. We have both, and that's nursing centers. We have continuing care retirement communities and life plan communities, and also for-profit members, and it really runs the gamut, and they are all over the state. I believe there are approximately 292 actually licensed nursing homes that again, go from, I would say on the low end, probably 30 to 40 beds to the high end. I believe we do have a facility in Martinsville that has around 300 beds, just to give you a little, just to give you an idea of the the scope of the facilities. Next slide, please. But a typical nursing home in Virginia has around 120 duly certified beds. More and more, they do short-term rehab services. We also have the goal that we want anyone who has the ability to have services provided in a home and community-based setting does that. Virginia has been a real leader in that really over the past 15 or 20 years, and the DMAS deserves a ton of credit for that. I believe, and again, this isn't, I think the information is probably a couple of years old, and I'm sure the AARP has updated it, but according to the AARP, we're, in terms of a balanced state in terms of home and community-based services to quote-unquote institutional care. Virginia is actually one of the top 10 in terms of the individuals that are in nursing homes compared to receiving home and community-based care. In other words, and it used to be different. I believe about 2/3 of the individuals receive home and community-based care, and about 1/3 they're receiving long-term care and support services receive care in an institutional setting. And if there's somebody from DMAS or even from our staff that wants to correct me on that percentage, they can feel free to jump in and do so. Before COVID, which has obviously been, had a significant impact on nursing homes, Virginia had a very healthy occupancy that averaged a little over 86%. So you would have about 102 residents in an average facility, and we serve about 90,000, patients per year. And I'm going to hopefully maybe if you can scroll down a little bit, Rebecca, on the slide. I don't know if I'm not seeing all of it, but we employ about 30,000 full-time employees, and half of those are direct care and therapy providers, with the biggest expense, being the personnel cost, which is a little under 3/4 of the cost of operating a nursing facility in the Commonwealth. But in terms of, in terms of economic activity, which is, something that we often get asked about, many times nursing homes are the largest employers in the Commonwealth, which gets to, one of Dr. Hazel's points that, tech jobs are very shiny, and, and everyone likes to talk about those. But honestly, whether it be community college or four-year colleges or even, private programs or those tech programs that come out of high school, we could employ as many CNAs, LPNs, RNs as the system, could produce, and then some. And that's really the uphill battle that we're fighting and have been fighting for a long period of time. And COVID-19 has obviously just exacerbated that situation. But we do have an economic impact of a little under $10 billion, through, with about 105,000, jobs in the Commonwealth. So that is very significant. And again, many times we are the largest employer, in a locality. Next slide, please. Many individuals are usually surprised to find out that 6 in 10 individuals that reside in a nursing facility rely on Medicaid to pay for their care. A personal story, my grandmother, I'm from Tennessee originally. If you couldn't tell from the accent, my grandmother, we felt had a very healthy savings. And then she was diagnosed with dementia and, had a very, severe, case of it, but she was very healthy, and she lived, a long period of time with that and spent through that and ended up on, the Medicaid program, which is called TennCare, in Tennessee. And that was not something that, that was something that was very hard for our family because, she had saved, for a long period of time to do that. And that's really a situation that many residents in nursing homes find themselves in. These are veterans, these are school teachers, these are local business owners that have just, again, they've spent through their savings, and they have a, longer period of illness than they, would think. And many times they've outlived their family members. And so the caregivers within the nursing home become their family members, later on in life. So they do end up transitioning to Medicaid. We do have, again, a small portion of self-pay, but again, many of those will spin down and become Medicaid recipients. Medicare is a growing portion because more individuals are able to receive stay for a shorter period of time in a nursing home, and then which is a great thing, and then are able to go home and resume their care. And so those are the shorter stay residents. So next slide, please. Yeah, and so the average age is a little bit under 80 years old, with 8.1 ADLs that are needed, and those are activities of daily living that an individual in a nursing center would need, and 54% have some form of dementia. One thing that I think is important at the bottom of this slide is that one of the things that we say in Virginia is that you have to be incredibly poor to qualify for Medicaid in Virginia, and you also have to be incredibly sick. Again, that's that's one of the reasons why that's an occurrence that, because of the rebalancing that we did. And so one of the things when we that I think DMAS talked about managed care earlier is that there was a hypothesis that many individuals could end up leaving long-term care facilities if their care was managed better. And that hypothesis many years in has proven not to be true. And we kind of knew that to be the case because, again, the individuals, if you go into any nursing center, which, again, I think everybody on the phone has either has a family member or through their work has been in a nursing center, that they're incredibly sick individuals that need a lot of help. And so, that's one of the things in terms of, if you are going to work in a nursing center and take on career, we really believe it has to be a passion because it's by no means easy work, and it's something that you really have to want to do day in and day out because, again, you could make more money, working somewhere else and go through far less training and probably have a lot less stress. So next, the next slide, just a little bit about where Virginia's Medicaid rates are. They are roughly about 10% below the national average. So there's been a lot of talk recently about the assistance that the governor and the General Assembly have provided to Virginia providers since the beginning of the pandemic, March 12th, which was when the governor declared his declaration of emergency. He provided a temporary $20 increase for COVID costs. That has gone, and I'll go through it on another slide, to a number of things, since the beginning. But one of the things that we continue to advocate for, with the General Assembly is that Virginia is a very low-cost state when it comes to Medicaid. This is not, just for nursing homes, but actually across all providers. But we estimate that since 2008, that we have been underfunded by roughly $600 million for our cost of care. And that this year in 2021 alone, again, pre-COVID, so these numbers will likely be higher, that there will be a $75 million shortfall. So next slide. So again, we talked about Medicaid being about 2/3 of utilization, but it only represents about half of the revenue of a typical nursing facility. Quite frankly, Medicare is and some other payers end up subsidizing the rest of the lower Medicaid rates, but it still ultimately results in still a very low operating margin of around 1.7%. This is not our data. This is actually from the Virginia Health Information Organization, and 2018 is our most recent. But again, what I would argue is Virginia has actually done a pretty good job within the past 6 to 7 years of providing an inflation adjustment through both the governor and the General Assembly, and we're appreciative of that. If not, that number could likely be far less, but it still results in 4 in 10 nursing facilities in the state having negative margins. So that's something that we obviously are always trying to work on. So I'm going to transition a bit to COVID-19 and the impact that it's had on facilities. So if we could go to the next slide. I think, can we go back one? Sorry, I think we skipped over one. No, we didn't. Okay. That's fine. No, we're good. We have had a significant drop in occupancy We actually just surveyed our membership and recently and had almost all of the members reply. And so we do have these numbers through July and hope to keep them, fairly updated as the pandemic goes on. There has been, sadly, an 11% drop in daily census. It is much higher in facilities with outbreaks. We have facilities that have had census drop as much as 50%. One thing to keep in mind is reduction. Occupancy does not mean equally reduced cost. And so if the state's paying us $196 a day per bed or $216 a day per bed with the extra $20 a day, then and individuals, not occupying that bed, it's not as though the expenses on that bed, equal to $216. So we estimate the revenue loss at $141 million from March to July, which is actually a little under 6% of the annual patient revenue. So that is something that is very troublesome, right now, and something that we, are taking a close look at. Okay, next slide. One thing, that we have, people have asked why, and I think it's more than a fair question, and is, why have long-term care facilities been hit so hard? One of the and not just in Virginia, but across the country, one of the reasons is just one of the things I talked about is how sick the individuals are that reside in nursing centers. One is at the beginning of the pandemic, we did not know that that the virus could be spread in an asymptomatic nature. The availability of testing has been big. Is it better than it was? It is. Is it where it needs to be? No. The availability of PPE, again, is it better than it was? Yes. But is it where it needs to be? It is absolutely not. But then also one of the factors is the location of the nursing home is something. If there's community spread in the area, then you can look, and you're more likely to have significant outbreaks in those facilities. And so it doesn't really get down to whether it's a for-profit, a not-for-profit, a government-operated facility. It doesn't get down to their 5-star rating. It is really, and I hate to make it sound so simple, but if we're not able to control the spread in the community, then then it is going to get into the nursing home. And again, we're 5 or so months into the pandemic, and that is something that continues to. The more academic literature that comes out, the more we see that. So next slide, please. And I've talked about the costs that they have been staggering. We have facilities that are they can't get the PPE from normal suppliers, so they are where they might have sourced from one supplier before, they might be sourcing from 10 to 15 now. Rightfully so, the personnel costs have increased through hero pay, overtime, a significant amount of contract staffing, which is not ideal. Daycare, sick leave, particularly when the caregivers test positive, and really the list goes on and on. And then the testing costs are significant, and that's something that again, we appreciate the Governor of the General Assembly's resources that they have helped provide us. But the average building, the cost to do one round of testing, for staff and residents is around $18,000 to $23,000, $18,000 to $23,000 per week. And so that's something that we are taking a look at now. Next slide. Next slide. There we go. Okay. So there has been support from the federal government and through the state. First, through the CARES Act, we are allowed to use what's called provider relief funds to help with testing, to help with PPE, to help, again, with staffing, overtime, and hero pay. And then, obviously, the $20 a day per resident per day has been incredibly helpful. One thing that I will say about the CARES Act funding is that we have not yet been told how to account for that. And so that might right now, and again, I'm talking about the CARES Act that was provided directly from the federal government, that funding right now probably is not as useful as we would have hoped it had been. We hope that changes fairly soon with information coming out. But again, we just have not gotten the guidance from the federal government that we would have hoped to by now. Then the next slide. So one of the things that's been done, and April Payne from our staff is on, is a temporary, in response to COVID-19, is a temporary nurse aid program that has been very helpful in having more individuals come into the facilities that can be of assistance. We have had extensive discussions with the Governor's Healthcare Workforce Advisory Council. I don't think that they envision that they would need to meet weekly, but they have been, and they have been, they have been able to assist with staffing when we've had crisis situations. Longer term, again, we have been involved with Fast Forward Virginia. We've just recently learned of the Claude Moore Scholar Programs effort that Dr. Hazel talked about, and we're very, very excited about that. And since 1998, we've awarded 490 scholarships through a foundation that the association has for a total of around $640,000. That does not include this year, when we and we're working through how many we'll be able to supply this year. But we hope to get, I don't think we'll get to $700,000 total, but hopefully we can get fairly close. And then the other thing before I end, and I'm happy to take any questions, is I did want to briefly mention that we do a significant amount of continuing education at the association, a lot of which is focused on workforce solutions, particularly recruitment and retention. As we've talked about, there is no silver bullet, for recruiting and retaining in any sector, much less the long-term care workforce. But it is something that our board and the foundation has put, has put a significant priority on, for a number of years. I want to applaud Leading Age for their efforts in training through their CMP program. And with that, I'm happy to answer any questions.
Yes, this is Lionel DeCure with Dignity for the Age, and I have a couple of questions.
Sure.
Number one, you mentioned a lot of different reasons for the spread of COVID-19 in nursing homes, correct?
That's correct.
Yes, and the one you failed to mention is I didn't hear you say anything about the lack of staff when, like, there are a lot of nursing homes with, say, one aide taking care of 20, 30, 40 residents, that there's been several recent studies coming out of Connecticut and also California by several PhDs that the lack of staff is causing COVID-19 to spread. Are you aware of these studies?
I am aware of some recent studies that have discussed that. COVID-19 is an evolve. And one, thank you for the question and your involvement. COVID-19, and we obviously know we're learning more and more about it, literally by the hour. I will say, just personally, before I, answer your question, is that I cannot imagine being a caregiver or a resident or patient in long-term care right now, or a family member. Not being able to see your family member, regardless of the best efforts of the staff at the communities to keep folks in touch as much as they possibly can. And we've seen some remarkable things in that respect. Nothing replaces face-to-face. And I think we all on this call would say that. I'd much rather be with you all in the same room than virtually. We initially, there was actually, and this is where I'm going to address your question, sir, is that one of the things that we initially saw is that actually if there were less staff, there would be less chance of spread. I haven't seen a number of studies, but again, I take your word for it. I do understand that there has been some information that's come out recently that a lack of staff, could contribute I don't think anyone anyone that has dealt with this virus would be surprised at anything at this point, to be quite frank. Again, to say it feels like the sand is shifting below the long-term care system's feet would be an understatement. So again, I don't dispute what you're saying. I'd be happy to look at anything that you have.
Yes. Well, I don't know if it would help, but what they're saying is that when you have so many residents to take care of, the CNAs are running from resident to resident, trying to change briefs to lay them on their side so they won't get pressure ulcers, to prevent UTIs. They're not getting changed, and they don't have these PhDs are saying, that they're not washing their hands when they go into the room. They're not washing hands during peri-care. They're not washing their hands after. And also, I'd like you to address the question. I know that many administrators of nursing homes, they get a bonus according to their bottom line. Is that correct? A lot of them do? You should know that information. That are there some administrators that get a bonus for their bottom line on their year end?
I'm not an operator, but what I would say is I do believe that if they meet budget, that they probably do have some type of compensation system, like many professionals, to where they potentially might receive some type of whether it be a bonus or retention pay or something of that nature. But again, I cannot speak specifically to that.
Yes, well, that's maybe something you want to become aware of because it's affecting so many residents. Also, I'm wondering if they would have a tendency to get that bonus, maybe to cut back on staff and also cut back on other materials.
What I would say is during this pandemic, and without exception, and I feel very confident saying this, that the nursing homes and assisted living providers across the Commonwealth have spent money on staffing, PPE, and testing, candidly, without regard for the reimbursement that they're going to receive. Again, that primarily comes from state government and also from the federal government. And so I would be very surprised to hear that they would cut back on staffing. To be quite frank, they are doing everything they can to try to hire enough staff to be able to treat the individuals. And so I think it is more, the other side of that equation. We've had a number of situations to where, and I talked about contract staffing, to where they would contract for nurses and it would be $100 an hour to $150 an hour, again, at the height of the pandemic, and they still were not able to recruit nurses to enter the facilities that had COVID-19 outbreaks. And that obviously, did not help, the situation.
Well, I understand that part of it, but you might, and not only you, because I don't know how much you're really interested in looking at that, but others might look into the fact that there are administrators, and I'm very familiar with this because I happen to belong to a large group of administrators, and they are, many of them, cutting back on staff and everything just to get to that bottom line so they'll get that bonus. That's all I have to say. And
Thank you.
Thank you. Are there any questions at this time for Mr. Hare?
Yes, I do have a question. Mr. Hare, I know you had sent a letter to the work group, which was distributed to them prior to this meeting. And one of the things that you had mentioned in there was higher compensation for employees, which is something that Ms. Green touched on during her presentation as well, as the compensation issue. What, to your mind, I mean, if wages and salaries are going to go up, what, to your mind, would be the solution to having the money to pay those higher salaries, and one or more solutions?
One or more. Well, One or more solutions. I think, you've had a lot of experts on the phone that can speak to this much better than I can. The first I would, say is we do need to ensure that there is an opportunity to be able to move, have a pipeline of individuals that are trained. And I know that right now we don't have enough instructors out there to train, whether it be LPNs or CNAs or RNs, particularly in the RN category, which is something we need more and more in long-term care settings because of the high acuity of the residents. We have more applicants than the class sizes will fill, and so we really need to take care of that issue. And I don't know. Megan might be able, if she's still on, might be able to answer, is that a pay issue? Do we need to pay them more? Because they're also an aging population, those instructors are. I don't think that, any of our members, if they, on the line would say that they, wouldn't like to pay, that, would be against paying, staff more. And that was one of the primary reasons when the pandemic began that they asked for additional assistance. But Virginia is a low-cost state when it comes to Medicaid, and so we really are dealing again with with about 80% of our reimbursement coming from Medicaid and Medicare. It really does, put a tight squeeze on operating costs, and you do have situations to where there are not-for-profit facilities that do have higher wages, but one of the reasons they're able to do that, which is a wonderful thing, is because they have a significant amount of charitable giving, associated with it. So, I think that would be the next thing, is to get the Medicaid rates where we need them to be, at a minimum at the national average. And I would argue they actually need to be higher than that, because one thing that they haven't taken a hard look at in Medicaid is, again, that acuity level, how sick individuals are, has increased significantly since we rebalanced in the last 15 to 20 years. You're not going to do that overnight, because that's an incredibly expensive proposition. I've spent, candidly 20 years working with providers, whether it be, in the private sector or, with the state. But, we have to start somewhere. And I think with the baby boomers, they turn 80 in 6 years. Then they're going to be, they're going to, I don't want to say overrun the system, but we need to ensure that we have the workforce in place to be able to take care of them the way we know we should. So I would say Medicaid rates first, but we also need to get, a pipeline of educators in there to ensure that, we could have 100,000, individuals that want to go into the system, but if we can't educate them, then, we're not going to get very far. And I'm sure there are many other ideas from smarter people that are on the phone or on the call.
And you may have covered this, and I may have missed it.
Mm-hmm.
I know you said that Virginia is under the national average for its reimbursement rates in Medicaid. Has that always been the case since the inception, or has it's been a trend that's?
No, we've always been incredibly low. It's a decades old problem, sadly. And again, that's across all Medicaid providers. I don't want to act as though that's exclusive to nursing homes.
Are there other questions for Mr. Hare?
Yes, one last question. Would that increase in Medicaid funding, would that wind up going to the investors in nursing homes, or would that actually go into hiring more CNAs and paying them better?
It goes to the investment that if we increase the rates, it goes to, again, what's called we have a per day rate, again, what I talked about. And so it goes, directly to that for the operations of the facility, which includes staffing.
Well, it could go into the investors if there isn't a law that's passed that makes sure that it doesn't go into the investors in nursing homes and not go into paying for additional staff.
I don't know if the Medicaid agency is still on the phone, but one portion of that Medicaid rate does have to do with staffing, and so it is recognized there.
Thank you for the questions, everybody. Are there any other questions before we move on?
I have a quick question. This is Susan Hines with Dignity. I was interested, Mr. Hare, in your temporary nurse aid program. Right now, Minnesota has an essential caregivers program in which family members can become helpers in a nursing home of their loved one. Is that temporary nurse aid program, do you think that's a similar thing?
I don't. That sounds like it's something different. I know Minnesota does a number of great things, and so I would love to hear more about that to see so that we can compare. I don't know if this is when I call for a lifeline. Is April Payne still on?
Yeah, can you hear me?
Yeah, we can hear you.
Oh, great, good, okay. I didn't think you could hear me earlier. Yeah, the temporary nurse aid is not. It is just that it's a temporary position. And Charlotte, I know, is here on the phone with us as well from the Board of Nursing. So the temporary nurse aid was developed in kind of in response to the federal waivers that we have right now for nursing homes for the federal requirements, which essentially allows an individual to take an 8-hour online training course, and then they have a competency checklist that the employer who would employ them as a temporary nurse aid has to complete. So again, I think the biggest thing here is it's temporary. It's in response to, again, the waiver, but also the fact that we do have employees when they're sick, we have an immediate need for staffing. And this position, temporary nurse aid, allows for us to bring somebody in and work under that capacity for that short period of time. It is something that we also have, since the program was launched, and our National Association, the American Healthcare Association, did this in partnership with CNAonline.com. But the hope is that those individuals who do, go through the training and become temporary nurse aides, that this would be kind of a launching point, a stepping stone for them to register and complete one of the state-approved nurse aid training programs, and then become a certified nurse aide. So again, this is a temporary position. I have had a tremendous amount of outreach from individuals who are either unemployed or just looking to make a change, make a difference, and help when they're hearing about the staff shortages and the challenges that we're facing in long-term care. So I think it's been very positive. The Virginia Community Colleges have, they're aware of this program, and also, looking at maybe even ways that they can use that 8-hour training and their actual hands-on experience in facilities to maybe apply that towards some of their curriculum. But those are all just, conversations that are happening because the temporary nurse aid is a new kind of concept right now, again, to meet that federal waiver and help us with the workforce challenges. So I'm familiar with some other states having different programs, such as you mentioned, sir. And we, our association actually created a personal assistant training. It's not for somebody to do, any type of skilled or, hands-on care, but instead to be, to be kind of another layer of assistance to our CNAs that, you can help pass meals if there aren't any dietary restrictions. You can help take mail to resident rooms, that type of thing. So we do have that also kind of side by side with this temporary nurse aid in an effort to help with some of, again, those immediate staffing needs that we are, we have been experiencing.
Thank you.
Then, for those of you who don't know, I'm assuming everybody knows April, and she hates it when I do this, but I love to tell her story. She, she started off as a licensed LPN at a facility in Northern Virginia, wonderful facility, Birmingham Green, and worked her way through college and just recently received her MBA from VCU, and she heads up all of the quality improvement and works a lot on workforce issues for the association, which is one of the reasons we brought her on, because we know of the crisis that's out there and really want to try to make some headway, which is one of the reasons why we're very excited about this group.
I would like to make a statement that I didn't get to make earlier, if this is okay, timing-wise.
Good. Let's just make sure that we have had an opportunity to hear all the questions for the presenters, and then if yours is a public comment, we'll do that as a separate section. Is that okay, Ms. Kukich?
Yeah, just didn't want to be forgotten. Thank you.
No, you're on my list. Are there any other questions for any of our presenters? I want to take this opportunity to thank Dr. Hazel from Claude Moore Scholars. I'd like to thank our DMAS presenters, Barbara Seymour, Ms. Hardwick, and Ms. Lee Austin. I'd like to thank the Real Chief Supervisor's Office, Megan Green, and Keith Hare from the Virginia Healthcare Association and the Virginia Center for Assisted Living. I would like to also mention that their presentations were full of really fascinating and detailed information. All that is available to you. I hope that each of you will go back and look at those presentations and learn more from those. I'm going to turn this back now to Ms. Allen to finish out the public comment portion of the meeting.
Sure, if you'll just give me a second, I'm going to throw the counter up on the screen. So just 1 second.
And before the counter begins, I just want you to know that this is not directed to any of the presenters today. This was supposed to be said before, so please don't take offense to anything.
All right, that's fine. All right, just whenever you're ready, I'll click start.
All right. As Director of Dignity for the Aged, I am saddened by the direction this work group is taking. I have attended all of the 3-hour meetings where the agenda includes topics related to everything but the current workforce and foundational issues affecting nursing homes. The bottom line is the elderly are dying as we speak. Many CNAs are being set up for failure and asked to do the impossible, and you're wondering why there's a problem with recruitment and retention? On behalf of the 800+ members of Dignity for the Aged and the thousands of residents being neglected and abused in more than 250 nursing homes in the Commonwealth, I want to go on record stating that the purpose of this work group has been hijacked. We can't wait 10 to 20 years to implement new programs. We need to stop the bleeding now. We all know the real problems regarding nursing homes. One is there are insufficient CNAs to handle the number of residents. The CNAs are not compensated adequately for their duties and responsibilities. Real estate and investment trusts are using their lobbyists to protect their interests. And politicians are doing the bidding of the real estate investment trust in return for monies to fund their re-election campaigns to remain in office. Unfortunately, elected officials and career government employees who took an oath to protect and defend the residents of the Commonwealth have sold out those people, especially those in nursing homes who cannot speak for themselves. Honestly, I don't know how members of this work group can go to sleep at night knowing they have once again slow-rolled the people of Virginia, unwilling to take on the nursing home problems that confront us throughout the Commonwealth. We are all well aware that the purpose of this work group has been written and mandated by those unwilling to change the real problems and make meaningful changes to establish ratios of 6 to 1. So, to the members of this working group, we're not going away. We will continue to advocate for the residents of nursing homes as well as CNAs who are trying to make things better despite the lack of care and understanding and willingness to address the real issues at hand.
All right, thank you, Ms. Kukich.
You're welcome.
Can everyone still see the presentation on the screen now? I just want to make sure as I flip back and forth between the content.
Yes, we can see it.
Okay, thank you. WebEx doesn't tell me when I switch back if it throws the presentation back up. So that, as Dr. Pratt said, concludes the presentations that we have set up for today. I believe, and I'm trying to pull the notes right now, we do have a few more topics left in the recruitment and retention piece, which includes staffing ratios. which will be on the agenda for next time. And since we have reached the end of the roadmap at that point, I think it would be a good idea for us to review all of the potential recommendations that we have come across to date in the second half of that meeting, and to see what other recommendations that the work group can brainstorm. I, of course, would welcome any thoughts from the, I'm sorry, who's that? Sorry.
This is Sam Kukich. Do we have minutes from the other meetings? Because it might helpful if we could review those.
Yes, I will send those out. All right. Well, with that game plan in mind, I will meet with Dr. Pratt after this meeting to nail down the outline of the agenda and see if there is anything that we need to reach out to individual stakeholders on. And we will be sending out the agenda to you, the minutes as Ms. Kukich asked, and we will see you all in roughly 2 weeks' time, keeping up with our typical schedule. And I know General Assembly is starting next week, so.
This week.
Sorry?
This is Senator Higgins. We start tomorrow, actually, but what is the...
Did I say next week? Sorry.
Yeah, that's tomorrow.
I wish.
Yeah, well, can you go over the timeline for how many more times you think this work group will get together, and when we plan on just finalizing recommendations that then will be presented, I guess, as a result of this group?
Sure. So I was planning roughly a work group session every 2 weeks, which is what we've more or less stuck to. So the next one, I was looking at the 31st, knowing that that's normally a day that works best for you, Senator Higgins, but I realize the session happening that day may not work for you. So we were thinking of something the week of the 31st, followed by something 2 weeks after that. So basically, 1, 2, 3, 4, that would be 4 more meetings. I think that equals that. That'd be 4 more meetings of the work group. So with the upcoming work group meeting being the kickoff point where we start reviewing everything we've talked about in terms of recommendations to date, that would give us basically half that meeting plus 2 more to, if we need them, to really nail down what the consensus of the work group is. And then after that 1, 2, 3rd meeting, Dr. Pratt and I would then come up with a draft to distribute to the work group members of what those recommendations would be, so that at the final meeting we could collect all the comments from the work group members to incorporate into that draft. So.
Okay, so probably into end of September, beginning of October?
Yes.
Okay, thank you.
Mm-hmm. And I will say, if we do need to schedule additional meetings, with the wonders of meeting electronically, if we need to, we can schedule additional meetings. But I'm hoping that the pace that we're on right now, 1 every 2 weeks, that'll give us sufficient time to nail down some consensus recommendations, put it into a draft for the work group members to review in time for the deadline that's in the bill. Is there any other comments before we wrap up?
No, I just, with Senator Higgins again, I just want to thank everyone again for their time. I know these meetings are a lot of information and hard to block off, 3 hours of your day. So thank you to everyone. It's really good for me as a new to the scene, senator, just to hear from everybody and all the stakeholders. And we all come from different directions and we all want the same goal. So just to keep that in mind, it's going to be, it's a work in progress. So I just appreciate everyone's input and look forward to, pushing through the next few weeks and coming up with some good suggestions that we can put in place here in Virginia. So thank you all for your help.
All right, thank you. And on that note, this meeting only took 2 hours and 41 minutes of your time this time around. So we are concluding a little bit early, which I'm sure gives us all time to prepare for session, which does start tomorrow. Thank you, Senator Kiggins. Apologize for messing that up. So thank you all for your time today, and I will be sending out the minutes along with the WebEx invitations for the next meeting. All right, everyone have a good day now.
Okay, thank you.